So let's wait Emma to give the green sign. Emma, can we start?
Yes.
Good. Okay, now it's 11 a.m. in São Paulo, Brazil, maybe 10 a.m. in Santiago, Chile. That's where Professor Alvaro Campero is staying right now for the meeting in Chile, in Santiago. And he is the invited speaker for our WFNS and Rhoton Anatomy Day Brain Subcommittee. And he was Dr. Rhoton's fellow back in 2004, almost at the same time as Carolina Martins, who is the chair of the Brain Subcommittee. And he's currently the chairman of the National University of Tucumán, a city located in the northwest of Argentina, South America. And also he's the current president of the Argentinian Association of Neurosurgery. He's a very talented neurosurgeon, one of the most skillful that I have ever I ever saw, one of the most skillful neurosurgeons, and he's very active both in academic in his private practice. He's a wonderful neurosurgeon, so we have the privilege to have him today to teach us about the anatomy, angiography, and surgery correlations of ACom aneurysms. Okay, go ahead, Alvaro Campero. Thank you so much.
Hello, everyone. First of all, thank you very much for the invitation. It is a big pleasure for me to be here. Thank you, Dr. Wen. Thank you, Dr. Carolina. And I am going to talk a little bit about the ACom aneurysm. Sometimes the ACom aneurysm is not so difficult in order to put a clip or treat endovascular, but sometimes it is a little bit complex because the branches and the size and the shape of the aneurysm. So it is very important to understand and to study the anatomy of that region. This is the Brain Institute where Dr. Rhoton had the laboratory. I work as a fellow in 2004, like Dr. Wen said. And our philosophy that we learned with Professor Rhoton is the following: from the laboratory to the operating room. So first, study and practice in the laboratory with the heads, with the cadaveric heads, and then go to the operating room. So first of all, some things about the circle of Willis that like everybody know, the blood supply, it's divided in the anterior and posterior circulation. The anterior circulation is about the internal carotid artery, and the posterior circulation from the bilateral vertebral arteries and the basilar arteries and so on. So the circle of Willis provides an anastomotic connection between the anterior and posterior circulation thanks to the PCOM artery, and with the right and left circulation thanks to the ACom artery, providing collateral flow when some arterial incompetence event happens. So we can see here circle of Willis. So this is the anterior cerebral artery in the left side, in the right side, and the ACom is between the ACA in one side and the other side. And posteriorly, we have the PCOM artery in the left side, in the right side, and continuing with the posterior cerebral artery in one and the other side. And here we can see the basilar artery and the P1 in one side and in the other side. So the ACom artery is a joint and communicate the left side with the right side. So, for instance, if we have some problem in one of the sides, the ACom acts to go the flow to the other side. So the anterior cerebral artery is the smaller of the two terminal branches of the internal carotid arteries and arises at the sylvian fissure at the medial end of the sylvian fissure below the anterior perforate substance. And the anterior cerebral artery is divided at the level of the anterior communicating artery into two parts, the pre-communicating and the post-communicating portion of the anterior cerebral artery. The proximal part extends from the origin of the ACom artery, from the origin to the ACom artery, constitute the A1. So we call from the origin of the anterior cerebral artery to the ACom artery, A1. And the distal part from the ACom to the distal part, it's divided in A2 infracallosal, A3 precallosal, A4 supracallosal, and A5 posterocallosal. So here we can see this is the right and the left optic nerve, the pituitary stalk. So here is the carotid artery, supraclinoid carotid artery in the right side, the carotid bifurcation, M1, and here start the anterior cerebral artery. So from the bifurcation to the ACom artery is A1 and or pre-communicating portion, and from ACom distally to the distal part, post-communicating artery. And here in this draw, we can see A1 pre-communicating, A2 infracallosal, A3 precallosal, A4 supracallosal, A5 posterocallosal. Here, this is a picture from front. So this is olfactory tract in the right and in the left, pituitary stalk, pituitary gland, optic nerve in the right, the chiasm. Here, this the ACom artery. So we can see the infracallosal here, the precallosal. This is the corpus callosum, precallosal, supracallosal, and in the posterior portion, the posterior callosal. This is another view in the left side. This is the ventricles. We cut the brain in the right side, so we can see here the precallosal portion, the supracallosal portion, and the posterior callosal portion. This is A3, A4, and A5. It's important to remember this. And in this picture, with the sagittal view of the encephalum, we can see the post-communicating A2 infracallosal, A3 precallosal, A4 supracallosal, and A5 the posterior callosal. And also we can see or we can recognize the same thing in an angiography. So this is the post-communicating infracallosal, precallosal, supracallosal, and posterocallosal. Another important things, the arteries from each side, these things are important because the surgery and in relation with the aneurysm. The arteries from each side, right and left, are typically not side by side as they enter the interhemispheric fissure, rather than one distal or one post-communicating anterior cerebral artery lies in the concavity of the other or in the convexity of the other. So the junction of the ACom artery with the right and left A1 is usually above the chiasm in around 70% of brains and in above the optic nerves in front around 30% of the cases. So the shorter the A1 is above the chiasm. The longer ones travel anteriorly over the optic nerves. So we can see here an anatomical view, optic nerve, right side, left side, olfactory tract. This is the internal carotid artery. Here we have the bifurcation, N1, A1, ACom artery, A2, the infracallosal, in the other side, in the left side, A2, A1, bifurcation, internal carotid artery, M1, pituitary stalk, superior hypophyseal artery, the diaphragm, and so on. Here we can see that if we mobilize posteriorly the ACom artery, we also can see the lamina terminalis. So usually the ACom complex is above the chiasm, and usually that is because the A1 is a little bit short and straight to that region. If we have a long A1, usually the ACom artery, ACom complex is above the optic nerve or the interoptic space. We can see another specimens with the similar view, right and left optic nerve, chiasm. This is the beginning of the lamina terminalis, the pituitary stalk with the superior hypophyseal artery. And here, this is the internal carotid artery, the bifurcation, M1, A1, anterior communicating artery, A1 in the other side, the bifurcation, carotid artery, M1. Another important concept, a normal anterior cerebral artery, ACom artery complex, is one in which the ACom connects two A1s nearly of equal size, and both A1 and the ACom are of sufficient size to allow circulation between the two internal carotid artery and through the anterior circle of Willis. But the A1 is the favorite site on the circle of Willis for hypoplasia. It's the majority. Many person has hypoplasia of one of the two A1. So A1 hypoplasia has a high rate of association with aneurysm. So because this lecture is about the anatomy of the aneurysm of the ACom artery, it is important to realize this concept. It is found in around 85% of ACom artery aneurysm, the hypoplasia of one of the two A1. So it is the only anatomic variant that correlate very hard with the location of cerebral aneurysm. So the normal, not the normal, but usually when we study the circle of Willis, we think about this. But usually in the relation with an aneurysm, one of the two A1 is smaller than the other. So we can see in this specimen very well. We can see this is the left optic nerve, left carotid artery, the bifurcation, and this is the A1, and we can see here an aneurysm, and we can see the right and left A2. So both right and left A2 is the continuation of the left A1. And we can see very small the A1 in the contralateral side, in the right side. So usually when we treat an aneurysm, it's very frequent to see that kind of thing. This is the right optic nerve, the hemispheric view of the right frontal medial lobe, and so on. And we can see in this picture, in this aneurysm, we can see in the left side, this is A1 in the left side and A2 of the left side. This is an aneurysm with one and the other portion. We can see all the aneurysms, like here, this is the neck of the aneurysm and the neck of the aneurysm. And this is the contralateral A1. So the A1 in the right side is hypoplastic, and in the left is big. And this is the A2 of the left side. So this is all the complex. So again, A1 in the left side, A2 of the left side, A1 in the right side, A2 of the right side, and the aneurysm here. So it is very frequently to see that kind of configuration of the arteries. Another important thing in relation with the ACom artery aneurysm is difficult. We have a difficulty angiographically sometimes to define the ACom artery, because it is frequently, we said before, not orientated in a straight transverse plane. Why? Because usually the length of the ACom artery is oriented in an oblique or straight anterior-posterior plane when an anterocerebral artery passes between the hemisphere behind the other. So the post-communicating anterior cerebral artery they are not beside, so one is in front and the other is beside. So usually happens something like that. This variation may explain why angiography in the oblique position is often needed to define the ACom artery. So if we use a strict perfil view, sometimes we cannot see the ACom artery, or in the pathology, the ACom artery aneurysm. So we can see in this surgical view, like a right pterional approach, we can see here, this is the right and the left optic nerve, this is the chiasm, this is the lamina terminalis, and this is a little bit of A1 and A2 in the right side, and we can see here the A1 and A2 in the left side. So we can see that the left post-communicating artery is in front, from the right side. So the ACom, that is very small, is not in a perpendicular plane, is an oblique plane. So if we want to see, we have to take the angiography like in this direction, because if we go in the anterior-posterior direction, we cannot see the ACom. And also, it is the same with the aneurysm. So it is important to understand that the ACom artery is not perpendicular, is in an oblique plane. And we can see in this, in another specimens, the right side view. This is the first cranial nerve, carotid artery, with the bifurcation here. This is the bifurcation. This is the M1, and this is the A1 and A2 in the right side, and this is the A2 in the left side. And this is the optic nerve, carotid, clinoid, and so on. So we can see here that the right side is posterior and the left side, I mean, in the post-communicating portion is anterior. So the ACom artery complex is not perpendicular, it is in an oblique position. That is why it's difficult with the angiography to find and sometimes small aneurysm.
Alvaro,
Yes.
the arrow is not always appearing when you want to point out something. I don't know
No?
why, but sometimes we can see, sometimes we cannot see the arrow.
Now you are looking or not?
I'm not,
No?
but in the previous slide, it showed. I don't know why, but anyway, that's okay.
Oh, well, I don't know why, because I can see in my screen. No, you
Yeah,
cannot see.
not now. It appeared sometimes and then disappeared other times.
I will
Right
try to
now, I cannot see. Yeah. I don't know if other people
not
can see.
again.
No.
You cannot see.
Now I can see. Very small, but I can see. Yeah.
Because I have very big, and I put big, but I don't know. Okay, let's see.
Now it's in this almost in the center of the slide.
Yeah. Okay. What about the recurrent artery of Heuner? Well, what the mean of recurrent? Say it of a vessel or a nerve, like a recurrent nerve, that somewhere along its course, it returns to the origin. So the recurrent artery of Heuner, it is unique among arteries because its recurrent path on its parent anterior cerebral artery to reach the anterior perforate substance. It is often, and this is very important for the surgery, it is often closely applied to the superior posterior aspect of the A1. So, for instance, if we are going to put a temporary clip, we have to take care about where is the recurrent artery in order to avoid to put the clip from the A1 with the recurrent artery. In Dr. Rhoton's study, there was a single recurrent artery in almost 30% of the cases, almost 50% two, and 3 or 4 in 24%. And it is very important also because usually in the majority of the cases or in the heads, it originated from the A2 just after the ACom in the 78%, from A1 in 14%, and at the joint between A1 and A2 in 8% of the cases. And also the recurrent artery is the largest and longest of the branches directed to the anterior perforate substance. Supplies, it's very important to realize that supplies the caudate nucleus and the anterior limb of the internal capsule. An occlusion may cause hemiparesis with facial and brachial predominance because of the compromise of the branch supplying the anterior limb of the internal capsule, and sometimes aphasia in the dominant side. So here we can see we can see the arrow when?
Yes.
Okay.
Very clear now.
Okay. So here we have the right optic nerve, carotid artery, bifurcation, M1, A1, A2 in the right side, A2 in the left side. So this is the recurrent artery of Heuner. It's in this case start almost at the level of the ACom. So this from here goes in this direction in order to entrance to the anterior perforate substance. Here we can see the same. This is another view, ACom, A1, A2 in the right side. The origin of the recurrent artery go very close to the A1. So imagine to put a temporary clip here, we have to separate the artery in order to avoid to damage this artery. go below the olfactory tract, going to the anterior perforate substance. So here we can follow the recurrent artery here and go in the medial portion of the anterior perforate substance. We can see the lateral ventricular striate arteries and some medial lenticular striate artery from the A1. And in this view, we can see all the trajectory of the recurrent artery. So again, right optic nerve, right carotid artery, right third cranial nerve, the right bifurcation, N1, A1, ACom artery, A2 in the right side, A2 in the left side. So the beginning of the recurrent artery go parallel to the A1 and at the level of the carotid bifurcation, separate and go to the anterior perforating substance. So here in this another specimen, we can see this is the anterior perforate substance. So this is the olfactory tract, optic nerve, pituitary stalk, third cranial nerve, and mesencephalon, and so on. So here the recurrent artery of Heuner has this direction, and here divide in two branches, one and the other branch to perforate the anterior perforating substance. We can see when they blow up. Here, this is the recurrent artery of Heuner, and here divide one branch, small branch, and the other small branch that introduce in this portion of the anterior perforate substance. So it is important, and then go to give supplies mainly to the head of the caudate nucleus and also to the anterior portion of the internal capsule. So usually the motor weakness after the lesion of the recurrent artery usually is at the level of the face and the arms. We can see in another specimens different situation. Here we have two recurrent artery. One, this is here, and the other, another recurrent artery that go to the anterior perforate substance. This is left optic nerve, left carotid, left third cranial nerve, the bifurcation, M1, A1, and one recurrent artery of Heuner going to the anterior perforate substance, another recurrent artery of Heuner that start at the level of A1, but also going to the anterior perforate substance. We can see with magnification, carotid artery, bifurcation, many perforated branches from N1, from the carotid, from the PCOM, and so on. But we can see also this branch, recurrent artery of Heuner, another branch go also to the anterior perforate substance, and small branches, the medial lenticular striate arteries that go also to the anterior perforate substance. And we can see in the other side, same specimen, in the other side, a very big branch, perforating branch, this that also we can call maybe a recurrent artery, but not with the very recurrent trajectory, but a very big perforating branch that go also to that portion of the anterior perforating substance. So it is very important to think in this different situation that we can have during surgery, because sometimes we need to put a temporary clip in order to work with the aneurysm, and we have to take care of these branches, perforating branches, and also we have to remember very well the recurrent artery. Other branches of the anterior cerebral artery, two, it is important to mention. the in relation, I mean, with the ACom aneurysm. One is the orbitofrontal artery, that is the first cortical branch of the post-communicating artery, arising at the level of A2, more or less 5 millimeter distal to the ACom artery. So first arise the recurrent artery, and then immediately after is the orbitofrontal artery. But it is important to remember that the orbitofrontal artery courses perpendicularly over the gyrus rectus and olfactory tract. So it drifts away from the A1 segment distally, whereas the recurrent artery goes parallel to the A1 segment. One goes to the gyrus rectus and the other continues parallel to A1 in order to find the anterior perforating substance. The other branch that we have to remember is the frontopolar artery. That is the second cortical branch of the anterior cerebral artery that originates also from the A2 segment, but more distally than the orbitofrontal artery, around 14 millimeters from the ACom artery. And different to the orbitofrontal artery, the frontopolar artery goes course in the interhemispheric fissure to supply the ventromedial frontal lobes. So here we can see very well the difference between the recurrent artery of Heuner that travels parallel to the A1 and very close, from the orbitofrontal artery that at the beginning could be close with the recurrent artery and also with the A1, but then go to the gyrus rectus and the olfactory tract. So it is important to differentiate both arteries. And the frontopolar artery work and travel in the interhemispheric fissure. So different first arise more distally and then goes inside the interhemispheric fissure. So we can see in with magnification, ACom here, A1, A2, recurrent artery, and orbitofrontal artery. Once the recurrent artery parallel and close to A1, and the orbitofrontal go to the gyrus rectus. What about the perforating branch of the anterior cerebral artery? More than the recurrent artery. We have the medial lenticulostriate arteries, and we have to differentiate the medial lenticulostriate arteries that arise from A1 from the lateral lenticulostriate arteries that arise from the middle cerebral artery. The number of medial lenticulostriate arteries varies highly between one and other specimens, but most medial lenticulostriate arteries arise from the proximal half of the A1 trunk. So if we are going to put a temporary clip in the proximal portion of the A1, we have to take care about the medial lenticulostriate arteries. But if we are going to put a temporary clip in the distal portion of A1, we have to take care about the recurrent artery because it is very close one to the other. And the perforating branches from the distal part of the A1 usually are smaller and go to the optic nerve, chiasm, and optic tract. So the lateral portion or proximal portion of the A1, we have many perforating branches that go to the anterior perforating substance mainly. And here in the lateral or distal portion of A1, usually we don't have too much perforating branches, but we have the very close the recurrent artery of Heuner. In this view also we can see that in the distal portion of A1, the recurrent artery of Heuner is very close to the A1, but then separate because one goes to the bifurcation, the other goes to the anterior perforate substance. So here we have to take care of the perforating branches. Here we have to take care about the recurrent artery of Heuner. What about the perforating branches of ACom artery? Because when we have an aneurysm in the ACom artery, we have to take care mainly with the aneurysm with the posterior projection about the perforating branches. So the ACom artery is frequently the site of origin of one or two, but as many as 4 branches. Most arise from the superior or posterior surface. So, for instance, if we have an ACom artery aneurysm with an anterior projection, probably we will not have problem with the perforating branches. But with the posterior projection aneurysm, sometimes it's very difficult to avoid to clip also the perforating branches. And the classification of the perforating branches of the ACom artery is subcallosal, hypothalamic, and chiasmatic branches. And usually their occlusion of that kind of perforating branches results in personality and memory disturbance, disturbance of conscience, mutins, and even internal environment disorder. So in relation with the subcallosal branch, usually is single and the largest, and usually arise from the posterior superior region of the ACom artery and runs toward the genu of the corpus callosum. It provides blood supply to areas including the lamina terminalis, an anterior portion of the hypothalamus, anterior cingulate gyrus, and rostrum and genu of the corpus callosum. So here, in this surgical view, subfrontal view of a specimen, we can recognize left optic nerve, right optic nerve, chiasm, carotid artery, bifurcation in the left side, M1, A1, in the right side, carotid artery, bifurcation, N1, A1, ACom artery complex, and also A2 in the left and in the right side. So this is the post-communicating or infracallosal or A2. So here we can see this branch from the ACom artery, and this is the subcallosal artery that go mainly to the inferior portion of the rostrum of the corpus callosum. We can see here with magnification the subcallosal artery. Also, we can see the recurrent artery of Heuner here and the orbitofrontal branch in the right side, and in the left side, the recurrent artery here and the orbitofrontal branch in the left side. So this is the subcallosal branch or perforating branch of the ACom artery. What about the hypothalamic branch? They are the most important because the consequence, if we clip or we damage during the surgery, could be very, very, very bad for the patient. Usually there are multiple and of small caliber, different like the subcallosal, and most originate from the posterior inferior region of the ACom artery and often coincide with the subcallosal. The subcallosal have direction a little bit more superior. And they provide, this is very important, they provide blood supply to the areas of the hypothalamus and the lamina terminalis. But the importance is the supply of the hypothalamus. And the symptoms when has some kind of damage water and electrolyte disturbance, disturbance of conscience, cognitive impairment, and high fever. And in severe case, this type of injury is life-threatening. So we have to take care when we are going to put a clip to avoid to clip or to have any damage to this kind of perforating branches. So in this specimen, we cut some portion of the frontal lobe, but we can see here, this is the ACom artery complex. We can see A1 in the left side and A2 and A3 after, and we cut this portion of A2 in order to can see and watch and realize the hypothalamic branch that go to the hypothalamus. So this branch we have to take care when we are going to put a clip, especially for the posterior projection aneurysm. And finally, the chiasmatic branches, it has the lowest occurrence of frequency and usually originates from the posterior inferior region of the ACom artery, but go to the front, to inferior and to the front, not to posterior like the hypothalamic branches. So provide blood supply to the optic nerves and the region above the chiasm. But this portion of the optic nerve and the chiasm also receive blood supply from the superior hypophyseal artery. So there are a lot of abundant anastomotic branches. So we don't have a big problem if we damage the chiasmatic branches, different like with the hypothalamic branches. What about the anatomy of the ACom aneurysm? First, and it is very important, the ACom artery aneurysm, or the ACom artery is the most common location for intracranial aneurysm and is associated with a high rupture rate, even for a small lesion less than 7 millimeters in diameter. Usually, in other part of the circle of Willis, usually we think that for an aneurysm to rupture, we usually from 7 millimeters or more. But in the ACom artery aneurysm, lesser than 7 millimeters also can rupture. And I would like to show an example. Subarachnoid hemorrhage, we can see, and we can see a very small aneurysm in the ACom complex, very small. Look, the brain with the very big and high subarachnoid hemorrhage, and we can see a very small aneurysm here, the right side. This is the ACom, A1 contralateral, A1 ipsilateral, A2 and A2, and the aneurysm very small with the blood because the hemorrhage, and now with the clip, so A1 in the right side, A2 in the right side, ACom artery, A1 in the left side, A2, sorry, in the left side. So we have to think that the ACom artery aneurysm can rupture very, 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 very small aneurysm. Another important thing, usually occur in the setting where one A1 segment is hypoplastic and the dominant A1 gives rise to both A2s. We said this before. So the aneurysm arises at the point where the dominant A1 segment bifurcates at the level of the anterior communicating artery to give rise to both the left and right A2 segments. This aneurysm usually point away from the dominant segment toward the opposite side, but maybe they also project in other direction. So we see this A1, the other A1 very, 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 very hypoplastic, and so the A1 bifurcate like in middle cerebral artery aneurysm. This is the contralateral A2, the ipsilateral A2, and the aneurysm in the bifurcation. And let's go to see some example, a huge subarachnoid hemorrhage. We can see the aneurysm here. So this is the A1, like a bifurcation of the left A1. So right and left A2 and the aneurysm in the bifurcation. So this is the view in the surgery. This is the ACom, A2 in the left side, A2 in the other side, and the aneurysm. And we have, this is the neck and the contralateral neck of the aneurysm. And then with the clip, this is the A1, A2 ipsilateral, in the other side, the A2 contralateral, and so on. Another important things, the term ACom artery aneurysm is a broad classification, not from the ACom artery, but could be at the junction of the A1 or an A2, or could be through A1 or through A2 aneurysm. So not just when we are talking about the ACom artery aneurysm, not all the ACom artery aneurysm start or arise from the ACom artery. Could be at the junction or at the A1, very close to the ACom artery, or at the A2, very close to the ACom artery. And we have two types, bifurcation type and sidewall type. Bifurcation usually are the most common and arise at the intersection of two vessels, but sidewall aneurysm, like a blister aneurysm, arise just one parent vessel. The most important factors in the majority of the surgeons, or at least our philosophy, when select the site of approach, is the dominance of the A1 in the preoperative angiotomography or angiography and so on. And the ACom artery aneurysm arise from a complex. We have to understand, because we were talking a lot about anatomy, but why? Because when we are going to treat an ACom artery aneurysm, we have to think that we have 5 arteries in relation with the ACom artery complex. Left and right A1, left and right A2, and also the ACom artery. So 5 arteries, but like an H letter. But also we have 7 additional arteries near the ACom artery complex that are the both recurrent artery of Heuner, the ACom artery perforators, and also the bilateral orbitofrontal arteries and the bilateral frontopolar arteries. So we have many arteries that we have to take care when we are going to put a clip. This is an interesting paper about triangles in order, or in anatomical triangles, but in relation with the clipping of the ACom arteries aneurysm. So we have many classification, but we can say that, or simplify the projection of the ACom artery aneurysm in 4 quadrants. So the aneurysm projection could be anterior, superior, inferior, and posterior. And this paper talk about 2 triangles, 2 surgical triangles, anatomical triangles. The A1, A2 junctional triangle and the A1, A2 precommunicating triangle. So aneurysm that project anteriorly or inferiorly are performing the surgery, in the A1, A2 precommunicating triangle in front of the ACom artery complex. And aneurysms that project mainly posteriorly are performed in the A1, A2 junctional triangle behind the ACom artery complex. And the junctional triangle is a potential space that opens, that is very important during the surgery, only with lateral retraction of the gyrus rectus or its resection, partial resection. So we have to take care about the recurrent artery of Heuner's cursus because it is in the center of the junctional triangle. And when we are talking about the precommunicating triangle, is formed by the right and left terminal A1 segment and the ACom artery. And it is a natural space that does not require tissue retraction or resection to open. There are no major arteries within this triangular space. So here we can see both triangles. The junction triangle between A1 and A2. So here we have the gyrus rectus. We have to push the gyrus rectus or to remove part of the gyrus rectus in order to see this. And in the middle of the triangle is the recurrent artery of Heuner. The other triangle is the precommunicating triangle. So pre, in front of the anterior communicating artery, ACom artery. And here we don't have any important artery or vessels. So usually we use the precommunicating triangle for the anterior projection aneurysm. We are going to see some examples and not so big subarachnoid hemorrhage, and we can see an aneurysm with an anterior projection. So this is the ipsilateral A1. This is the ipsilateral recurrent artery. Here we have the ACom, and here we are not seeing the A2 because we don't need, we just have to put a clip here. We don't have any perforating arteries here. So this is, here we have the other A1, left optic nerve, right optic nerve. So here we go and put the clip. And we can see the pre-op and post-op angiography. But for the posterior portion or posterior projection of the aneurysm, sometimes or usually we use the junction triangle between A1 and A2. But we have to sometimes to push up the gyrus rectus or to remove part of the gyrus rectus. And we can see another aneurysm with the posterior projection. So here we can see left side pterional approach. This is the left optic nerve, left carotid, left A1, the recurrent artery, A2 here. This is the gyrus rectus, A2 contralateral, ACom artery, and here we have the aneurysm. So we use the junctional triangle between A1 and A2, and we put the clip with this view. Now with the clip using the junctional triangle. So here this is A1 and A2, the beginning of A2, ACom artery, and A2 contralateral. And we can see the pre and post-op angiography. Another example, a big subarachnoid hemorrhage with the big aneurysm with the white neck. We can also see with the 3D projection, and we can see here many branches. So this is A1, this is A2, a very white neck and many branches. This is the contralateral A1, very small, and putting the clip also in the junctional triangle between A1 and A2 ipsilateral. So sometimes we need to use this triangle. But also, I think it's not in this paper, but I think that sometimes we use another kind of triangle that is not pre-communicating, is post anterior communicating artery between the A1, the A2, and the A2 of both sides. And I will try to show some examples. This another aneurysm with the 3D. And now in the right side, we can see A1 in the right side, A1 in the left side, A2 in the left, A2 in the right. We cannot see because the aneurysm, but when I mobilize, we can see. And now we use this, not this triangle, not this triangle, but this triangle between both A2. And we can see also the CT angiography. Another example, also with the bifurcation from the right side. Usually we use the dominant vessels to perform the pterional approach in the 3D projection. And the same thing, we can see here A1 in the right side, A1 in the left side, A2 in the contralateral, A2 in the ipsilateral. We can see the recurrent artery of Heuner and the orbitofrontal branch. So we have one neck and the other neck. So we don't use this triangle. We don't use this triangle. We use this triangle between both A2. And now with the clip, I'm sorry, and the recurrent artery, another recurrent artery or perforating branch from A1, and also the orbitofrontal, and so on. Another example with the huge subarachnoid hemorrhage with not so big aneurysm, and the same thing in this triangle between A2 from one side and the other side, and the clip at the end. Another example, the same with a pseudo aneurysm here, and the same thing. This is A1 and A2. This is one triangle, this is another triangle, and this is another triangle that we use to put the clip. Another example with the huge subarachnoid hemorrhage, the same thing, A1, A2, A2 in the other side, and with the clip. Another example, big aneurysm with the wide neck. Sometimes we need to use more than one triangle. So here we can see this is the A1 and A2 in the left side, a very big aneurysm. We have to perform the reconstruction of the ACom artery. So first we use the anterior triangle in order to put. We can see now the A2 contralateral, but yet we have some portion of aneurysm here, so we have to use also this posterior triangle in order to clip that portion. And we can see this is the pre-op and the post-op with one clip here, another clip here, and we can see better maybe in the 3D reconstruction. This is the pre-op, and we can see the post-op with the reconstruction of the ACom artery. I would like to show 3 short videos. With this, I will finish my lecture, one aneurysm that the origin is from the left A1 artery. So now left pterional approach. This is carotid artery A1. We can see here the recurrent artery. We are cutting the arachnoid above the chiasm in order to go to the aneurysm. We can start to watch the aneurysm, but we have here the gyrus rectus. So we are going to remove a little bit the gyrus rectus. We start to see better the aneurysm. This is the contralateral A1. We can see the neck of the aneurysm, but in that time, I didn't feel so comfortably. We can see here the recurrent artery of Heuner, contralateral recurrent artery, but I cannot see very well. So we are going to put two temporary clips. So we have to see that we don't have any perforating artery and recurrent artery. So here is the recurrent artery. We are putting two temporal clips. So we are mobilizing the aneurysm, and look, you can see that the contralateral recurrent artery of Heuner is very close to the aneurysm. So we have to cut the arachnoid and to separate the recurrent artery from the aneurysm. So we are cutting, but for that reason, we put and we used temporary clip. So after that, we feel comfortable to put a clip, avoiding to clip or to damage any perforating branches like the recurrent artery. And this is the final position, and we can see all the anatomical things. Another case, another ACom artery aneurysm, we can see in the 3D reconstruction. In this case, we use the right pterional approach, the same thing from the carotid artery to the bifurcation, and then following the A1 artery going to the interhemispheric fissure. We can see A1 ipsilateral, recurrent artery ipsilateral, A1 contralateral. So now I can put a temporal clip without any problem. Now I am going to remove a little bit the gyrus rectus in order to visualize better the aneurysm. I am sucking the gyrus rectus, and here we can see very well the ACom artery and the contralateral A1. This is the neck, and the neck, one artery, probably frontopolar artery that crossing the aneurysm, but the contralateral recurrent artery of Heuner. Now I am going to put a clip, a cure clip, in order to clip the aneurysm, but let's see what happened. After that, I cut the aneurysm, because a big aneurysm, it is completely with occlusion. But the problem is that the contralateral A2 is also without blood, without flow, because this is a real A2 aneurysm. So in this case, I put 3 temporary clips, of course, taking care about the both recurrent artery. I also put in the A2, sorry, ipsilateral. So I will put a clip above the anterior clip and remove the first clip, because otherwise the patient will do an ischemia in the post-op. And now we can see the A2. So this is a true A2 aneurysm, no an ACom aneurysm. Maybe in the angiography seem to be ACom artery aneurysm, but we can see during the surgery that this an A2, a true A2 aneurysm. And we can see the post-op 3D angiography and similar with the picture during the surgery with both two clips in the beginning of the A2, contralateral A2. And the last case, and with this I will finish, with also a difficult aneurysm with the in the left side. So now we are cutting the arachnoid. This is the A1. We can see we are opening the interhemispheric. We can see A1, the other A1, very hypoplastic, many branches. This is the A2, the contralateral A2. Now we are removing part of the gyrus rectus. We can see many branches. This is branches that go to the frontal lobe. This is one of the neck, very complex aneurysm, A1, A2, A1 in the other side, A2 in the other side. So this is the recurrent artery of Hebner. We have some perforating, we have to take care. So we have to find a place without perforating branches to put the temporary clip. And now we are clipping the aneurysm, very complex aneurysm. But if we can see all the branches, it is better and we work comfortably. Now we are using a booster clip in order to give power to the clip. But now we have another portion of the aneurysm. So now we are going to put another clip in order to do the occlusion of all the aneurysms. And this is the final view with the all the branches without the clip. So finally, I would like to say, because our philosophy that we learn with Professor Rhoton and with Dr. Wen, with Dr. Carolina, and so on, is to try to learn and to practice in the laboratory all the anatomy and the 3D anatomy and the practical anatomy in order to can use during our surgery. Thank you very much.
Oh, Alvaro, that was a very comprehensive, view of the anatomy and geography and outstanding surgical skill. I want to congratulate you for this is such a fantastic talk. Thank you so much. Now how important, all the audience can witness how important is the anatomy, and then go get your anatomy knowledge into the surgery, and how, maybe the best way to get surgical skill is to do more and more surgeries. I don't know if you agree with this, but Alvaro is that you can tell Alvaro is an outstanding, very skillful neurosurgeon, very gifted neurosurgeon. Now we can open for questions. If you have any question, just write it down on the chat so we can ask Alvaro. And while you are writing questions, can I ask you a few questions?
Yeah, of course.
And do you have any preference when you approach from the right side or when you approach from the left side? What kind of criteria you use to decide I have to go through this side? No, this aneurysm have to go through the other side. Can you share your thoughts with us?
Yes, of course, I prefer to go from the right side because first, the dominance and for the patient, and second, because I am right-hand surgeon, so it is easier or more comfortably. But in ACom artery aneurysm, I choose the right or left side because the the pattern of the aneurysm. See if the aneurysm arise from the right A1, of course, I go from the right. But if it arises from the left, I prefer to go from the left side. I know that some surgeons usually use in both cases the right side, but I prefer to have proximal control. So that is the reason why I choose according with the pattern of the aneurysm, because I feel comfortable to have proximal control in order to put a temporary clip if we have a bleeding, an early bleeding during the surgery.
Okay. Another question is, does it make any difference? For instance, aneurysms is projecting downwards. So obviously you have to go through the side that fills the aneurysm. For instance, the aneurysm, it fills with the right A1. You have to go through the right side. But if aneurysm is pointing on angiography, pointing up or backwards, does it make any difference? Because the aneurysm will be hidden, protected by the rectus gyrus.
Yes,
So
yes,
yes,
good
go ahead.
question, because some surgeon also, I think the Japanese, many Japanese surgeons sometimes depend the projection use interhemispheric approach or subfrontal interhemispheric approach. I usually use the classic pterional approach. Sometimes I perform a fronto-pterional approach in order to go a little bit more subfrontal, but I feel comfortable with the pterional approach in order to go more posterior, more anterior, transsylvian, and so on. I think the pterional approach has the versatility to use all the views, subfrontal, a little bit lateral frontal, or transsylvian. So in our philosophy, we always use the pterional approach, no other approach.
Let me see here. Here we have a question from Dr. Pascal from Alexandria University from Egypt. And he wrote, "Thank you for this amazing presentation. How do you choose the side of approach according to the position of the A2? I mean, when one is anterior to the other.
Yes,
When you see them, did you
yes,
get the question? Okay, go ahead.
yes. I think it is the same like you asked before, Juan. Usually with the pterional approach, I didn't talk about pterional approach because no time, but usually with the pterional approach, you go more frontal, more transsylvian, or more posterior. So the pterional has, in my opinion, the versatility to use all the view that you need from the ACom artery aneurysm. You don't need to go, in my opinion, interhemispheric or lateral frontolateral approach, and so on. I usually open the sylvian fissure and go more, put the microscope more from anterior to posterior, more lateral, according to that important thing, the position of both A2, also the position and the projection of the aneurysm, and so on.
Do we have any more questions? And when do you use the orbital pterional approach?
You mean with the removal of the...
Yes, additional removal of the orbital ring, just a little piece of it.
In the ACom aneurysm?
Yes.
We don't use.
You never have to use that.
No, we actually, it is very, very rare that we use orbitofrontal or orbitozygomatic approach in, not just in ACom artery aneurysm, in any tumor and something like that. In the past, we use very often, but now with a good pterional approach, with a good drilling of the roof of the orbit and so on. I think that you don't need. Sometimes we use, for instance, if we have an intraorbital and intradural lesion, but for ACom artery aneurysm and also for tumor, we don't use anymore the orbitozygomatic approach.
Mm-hmm. I share the same opinion as you. Um, we have another question for Alvaro Villanobona. Thanks for this great lecture. How do you deal with cases when multiple perforating arteries originate from the aneurysm?
Hmm.
That's a
Well,
bit difficult, but try to answer that.
it is. It is very difficult, not just for the ACom artery aneurysm, but for any aneurysm. Usually, fortunately, we don't have usually that situation. But in the case that there are many perforating branches from the dome of the aneurysm, it is difficult because you don't know if you put the clip and clip the aneurysm and also the branches, what will happen. It is so I don't know. It is difficult to answer this question. You have to be in this situation to see the situation of the patient, the possibility to do another treatment, like for instance, an endovascular treatment, if was with the hemorrhage or not, and so on. So it is, you have to to take a decision in this kind of situation. It is difficult to, because could be many possibilities. You, I will try not to clip, at least with voluntary. I try not to clip any perforating arteries, because if that perforating arteries are the hypothalamic branches, probably the patient will have a very bad post-op with the maybe never wake up. So we have to take care about that.
Yeah, maybe I don't know. I don't know the answer either, but whenever possible, we try to avoid clipping the perforating arteries, especially when the perforating artery is rather big. But maybe in the intraoperative monitoring, physiological monitoring can give you more information. You clip and watch the waves. Ask the neurophysiologist to see something if something is happening, and that might help. But once again, you have to have at your disposal, the intraoperative neuromonitoring. So, but whenever you don't have it, maybe the best advice is better to spare the perforating arteries. Okay, and then maybe one more question, Alvaro, if you don't mind. It's Dr. Vincent from University of Nairobi from Kenya. And he said, thank you for a great talk. Would you have approached the A2 via a different technique? I didn't quite understand. How do you approach the A2 with a different technique? Just, maybe not only Teriona approach. So, but you just told us you have used Teriona approach for all your ACom aneurysms, right?
Yes, but other surgeons use, for instance, the interhemispheric approach. So another possibility is an interhemispheric approach. Another possibility is just a frontolateral approach. So of course it depends. It depends the surgeon, but usually for ACom artery aneurysm, you have these three kind of approach: interhemispheric, frontolateral, and classic Teriona.
Mm-hmm. And just I was thinking about the Dr. Pascal's question from Alexandria University in Egypt. Probably he was asking about aneurysm array, pointing up on angiography on lateral view, aneurysm pointing up. And on lateral view, you can see that one A2 is in front. It's not at the same level on the
Yes.
lateral view. One is in front, one is behind. So he was asking, probably his question was, is that better to approach from the side that A2 is behind? For instance, left A2
Yes, yes,
is behind and right A2 is in front. So which side would be the best?
yes. Of course, it is better to the ipsilateral um, posterior because you can see better the neck of the aneurysm and to put the clip. But again, I first prefer to have the proximal control. So if I have the A2 in front, so it will be a little bit uncomfortable for me. Also, I prefer to have proximal control and go from the posterior triangle.
Okay, wonderful. Because if you approach from the A2 that is located in front, you might have to use the fenestrate clip because it's right in front between you, the surgeon, and the aneurysm. So
That's right.
maybe approaching from the A2 that is located behind, the aneurysm would be right in front of you. So instead of, using fenestrated clip, you use the regular clip.
It is
Maybe
better
this is
in that situation. Yes.
uh-huh. So maybe our time is up. So I would like to thank you once again so much for your wonderful talk. Very comprehensive. One of the best talk about ACom aneurysm I have ever seen. And I would like to thank all the audiences, and they are watching live. And but I also want to remind you guys that his presentation, all the presentations from the WFNS and Rhoton Anatomy Day, uh, they are all recorded. So it will be played maybe tomorrow. And so if you want to watch again, you'll be able to do this. And also what I like to remind, every first Friday of each month is going to be about peripheral nerves. Every second Friday of each month, it's going to be about skull base. And every last Friday, just like today, it's about the brain, then the brain anatomy and the related surgery. So once again, I thank you all so much. I thank you so much, Alvaro. Thank you, Imad, for this wonderful webinar. Thank you all. So thank you so much. See you guys next time. Thank you, Alvaro.
Thank you very much, Gwen.
Thank you.
Bye bye.